So welcome. My name is Professor Nora Colton. I want to welcome you to this UCL lunch hour lecture on ethics and the future of health. As I said, my name is Professor Nora Colton. I'm the founding director of the UCL Global Business School for Health and a professor of leadership and management for healthcare. We are going to share briefly a video with you.
200 years ago, there was no university in London, and we're really marking the coming of a very radical, very different institution to a city that was the largest city in the world.
UCL was to be open to people of all faiths, or indeed no faith.
Women were admitted to the Slade School of Fine Art when it opened at the start of the 1870s, and from 1878 women were able to come to UCL, study alongside men and get a degree. And this was way before any other university was giving degrees to women.
In UCL's bicentennial year, you can expect a major new exhibition, 3 books, installations from renowned artists, and UCL Illuminated, a spectacular immersive sound and light show on our central London campus.
The main chord is going to turn into a multi-day theatre with filming, workshop, lights, laughter, comedy, theatre and drama. It's going to be magic.
I'm really excited about telling people the story of how we as an institution have evolved over 200 years and how we're going to evolve for the next 200 years.
Okay, well, I hope you enjoyed that video. It's my honor and pleasure now to introduce my colleague today and speaker, Dr. Johann Go. I'm going to tell you just a little about Dr. Go before I have him give his lecture today. Dr. Johann Go is a political philosopher and applied ethicist, having recently joined UCL's Global Business School for Health as an assistant professor in health ethics. Dr. Go's research focuses on theories of social, global, distributive justice and their application to debates in health and public policy. He has published in leading international venues, and his book, Health for All, A Theory of Global Health Justice, will be published later this year by Bristol University Press. Dr. Go is passionate about public engagement and interdisciplinary dialogue, being active in policy and public outreach work alongside his academic research. Before we begin, I wanted to let you know that we will have some time at the end of this lecture for questions, and these can be submitted at any point during the talk by going to Slido, entering into your internet browser, and entering the event code #UCL Health. I now have the great pleasure of handing it over to Johann for his talk.
Thank you very much, Nora, and thank you to everyone for joining us. So what you see on screen at the moment is a pulse oximeter, a small, simple, and important device that's used in healthcare to measure oxygen levels in your blood. Now, many of you will be familiar with this device because it was very popular during COVID-19 as a way of monitoring oxygen saturation levels, whether we're at home or in hospital. But even before COVID, pulse oximeters were one of the most common medical devices used in everywhere from home health to ambulances to hospital wards and intensive care units. But we now know that pulse oximeters can overestimate oxygen levels in people with darker skin tones and therefore hide the true dangers that might be lurking beneath their condition. So you might see a supposedly objective number on this device, but it hides an underlying story about how that device was designed and for whom. So a patient may come in with a 99% oxygen saturation rate, but that means something different if you have fair skin or dark skin. So the same figure, the same reading on a darker skinned patient may in fact hide the fact that they have dangerously low blood oxygen levels. So this story is just to open up the thinking about this issue around innovation and technology in health to show that when we design health technology, it's not always everyone that benefits equally, or that it's not always the assumption that everyone will not be harmed. It's easy to get swept up in all the excitement about health innovation. There's just so much going on, so many exciting things, robotics and surgical techniques, the use of personal medicine and genomics, new drugs, cutting edge digital tools, just to mention a few. And this excitement about health innovation and technology can sometimes hide or cause us to miss important underlying ethical considerations. Now, my talk won't be just about pulse oximeters or medical advances as such, but I want to share a broader story about how to count benefits and burdens when we innovate in health and for whom. And the core message that I will try and drum in this public lecture is that ethics needs to be at the center of health innovation. What do we mean by that? Well, one thing I will argue for is that to put ethics at the center of health innovation for the future is to see ethics as a design constraint. So when we look at the majority of innovations in health, the focus on ethics tends to come after the innovation has been designed, if at all. And this is what I call the idea of ethics or equity as an implementation constraint. So people say something like, we have invented this piece of technology, now let's think about rolling it out ethically. But I will argue that ethics needs to be integrated much earlier into the innovation life cycle. And ethical considerations around health equity, which is one of the major ethical constraints and ethical considerations in healthcare, needs to be started much earlier and act as a design constraint. So instead of asking, how do we roll out a technology ethically once it has already been designed, we start much earlier and say something like, how can we design this device or this technology so that it is ethical and equitable by default? So in this public lecture, which I can assure you that you require no background in either ethics or health for, I'm going to try and do the following. I'm going to start by introducing 3 case studies to show how innovation that's focused solely on ethics as an implementation constraint rather than as a design constraint can undermine health equity. I'll then outline a new framework for thinking about this, which I'll call the equity-weighted framework for responsible innovation. So briefly, I'd think we should be more willing to innovate when benefits fall on the worst off groups and less willing to innovate if harms and risks fall on those same worse off groups. I'll then explore some theoretical justifications for this framework, and so parts 2 and 3 will be the core of the theory behind this. I'll then turn to the practice. I'll look at how this framework could be applied in practice, everywhere from NHS procurement policy to more research funding incentives. I'll address some objections, including the view that maybe this would stifle or slow down innovation. And I'll conclude with a basic diagram to help us think through what responsible innovation, starting from the design stage, could mean. So let's start from the beginning. What is ethics? Many of you may be wondering. Well, all ethics is the systematic study of what makes actions or state of affairs right or wrong, or better or worse. Now, many people think that ethics is all about trolley problems, deciding whether we should divert the runaway train into a track to kill 1 or 5 people. But there's more to ethics than the trolley problem, even if it does capture one important dimension of ethical dilemmas that we may be faced with in healthcare. Ethics is also about reflecting on the broader nature of what we want our society to look like, including in the sphere of health and its future. One ethical idea that is highly influential in health is the idea of equity. And all health equity means is that we are thinking about health from the perspective of fairness, of justice, and appropriately distributing opportunities for health. And this is one of the most common ideas that's used by researchers across all areas of health, which is a deeply ethical idea, even if it's not always recognized as such. Let's turn to those 3 case studies we mentioned. So recall the opening story of this talk, the case of the pulse oximeter and the two readings for the two different patients. Now, that story is important because it shows that innovation and technology are not morally neutral. So decisions and assumptions would have been made at some point in the innovation life cycle that meant patients with darker skin may have been harmed by such technology. And these assumptions are ones that ethics is especially well placed to question. But is this an implementation issue or just a design flaw? Or is it both? Well, I think it can be both, but we should not see it merely as an implementation issue, which is the prevailing way that this problem has been addressed. So it's not just about clinicians being more aware of the limitations of the device. It's about questioning the underlying assumptions that might have overlooked that problem at the design stage. And this, as I said, is an important way ethics can contribute to our thinking about innovation. Second case study is to do with AI and algorithmic bias. So many predictive health models in the US, in particular, use cost as a proxy for determining medical need. So, for example, if a particular health planner, whether in the private or public sector, wants to estimate the level of medical need within a particular community, they will look at past healthcare costs and expenditure as a proxy for health need. So higher cost and spending on healthcare would mean higher need, lower cost and lower spending on healthcare would mean lower. So lower cost and spending would mean lower medical need. And so cost here is used as a proxy for medical need. But the problem with this predictive AI model, which is widely used, is that it grossly underestimates medical need among Black and poorer patients. And this is because we have evidence that Black patients and poorer patients face barriers to care. So it means that less is spent on them, or if they spend privately, they tend to spend less out of pocket due to other dimensions of existing socioeconomic disadvantage. And this highlights the idea of algorithmic bias, where the assumptions and issues in the data we use behind the training of algorithms, including these predictive tools, can actually exacerbate health inequities. So what we want is to shift this thinking into thinking about ethical algorithm by design. So we want an algorithm that is ethical by design, not something we simply tinker around with on the edges once we discover some flaws in its outputs. And the final case study we're going to look at is around the area of clinical trials. And this is one area, again, where we could benefit from greater integration of ethics at the design stage. So we know that there have been improvements, but clinical trial participants tend to be disproportionately of a certain background, often white and male. And this can hide concerns around side effects and efficacy with drugs for certain groups. So consider this common drug, which is clopidogrel, which is used to prevent blood clots in patients who have had a heart attack or stroke or are at high risk of these conditions. Now, people with a particular allele, a gene allele, have the effect that they do not benefit from this medication. So we know that about 70% of East Asian patients have this allele. And it means that clopidogrel not only doesn't work for them, but it can actually make the bleeding worse. And so this is what cardiologists have called the East Asian paradox of clopidogrel, where it not only doesn't work, it makes the condition much worse. This shows what can happen when initial clinical trials don't think about ethics and equity at the design stage. And so what happens is the benefits and burdens of innovation can sometimes be missed when we fail to take into account the importance of thinking about representation in clinical trials and so on. Issues of gender bias have also been noted within clinical research. So women are often excluded from clinical trials, especially pregnant women or women of childbearing age, out of concern that they would have, there would be potential effects on either their unborn child or on a potential unborn child. But this decision, whether right or wrong, means that medications are researched with male-based cohorts and male-based dosages, and we have much less information around efficacy and safety in other groups. So all of these case studies are a snapshot into what can happen when ethics is either not central or is an afterthought in the innovation life cycle. So to put ethics at the center of health innovation, I'm going to spend the next few minutes outlining a framework that we can use called the equity-weighted framework for responsible innovation. The title is much more complex than it seems. It's the simple thought that we should weigh considerations of benefits and burdens in proportion to equity considerations. So benefits matter more when they help worse off groups, and harms also matter more when they affect worse off groups. Another way to phrase this is that when benefits or harms fall on the worse off, they should count more in our ethical evaluation. Or for those who want a more formal statement, the moral value of an additional unit of benefit is greater, and the moral disvalue of an additional unit of harm is worse, the worse off the affected group is. It's also important to think about the kinds of harms we mean. And here I want to introduce one way we can think about this distinction. So there are two harms or two kinds of harms we should be aware of. The first is a very simple harm of commission or harm of acting. And most people know about this, right? So if you roll out a biased AI system in health that causes harm, then you've created, harm by acting. But there's also a second type of harm that's less familiar to many people in the innovation space. And this is the harms of not acting or the harms of omission. Because not innovating can also entail harm when we fail, for example, to reap the benefits of what could have been the case. So if we fail to roll out a well-designed e-health platform to improve access for those in rural areas, then we could harm these patients by not acting because we're causing them to miss out on something they would otherwise have access to. And ethical innovation requires us to balance both these kinds of harms, not just the harms that come from acting, but also the harms that come from not acting, not innovating, and letting the status quo stand. The final distinction that is worth keeping in mind is what philosophers call ex ante and ex post considerations. So when we weigh equity on my framework, we need to think about this in both an ex ante and an ex post way. So one way to think about ex ante is to think about it as risks before. So we weigh the issues of foreseeable inequities during design and prior to deployment. Ex ante, before. Ex post corrects inequities that emerge during or after deployment. So here, ex post refers to after. And equity weighting requires us to do both. We need to keep in mind not only the before, but also the after. So I'll pause there because many of you might be thinking that broadly makes sense. Some of you might be saying that's totally wrong. And some of you might want to hear more about why we should support this kind of framework. So in this final theoretical section, I want to explore some ethical justifications for why we should support this framework. And I'll explore a number of different arguments. So I'll explore a set of arguments around diminishing marginal utility and a moral theory called prioritarianism. I'll explain some Rawlsian arguments you might think could support this view. I'll also highlight an argument around asymmetric vulnerability, why it is that some people are better able to bear risks than others. And keeping in mind that health is always sensitive to the requirements of justice and ethics more generally. And so health cannot operate independently of these issues. So the first justification for the equity-weighted framework comes from a philosophical theory known as prioritarianism, and the related concepts in value theory around diminishing marginal utility. So the key idea behind prioritarianism is that we have greater moral reasons to help the worse off that person is. So we have greater reasons to help those at the bottom of the ladder. And this is partly justified on reasons of diminishing marginal utility, which may be familiar to many economists. So take a look at that slice of cake on the screen. So suppose you haven't had any cake that day, and you're offered that plate of cake. You derive a lot of pleasure and value from eating that cake. You might even enjoy a second slice if you're offered one, but you're not going to enjoy that second slice almost as much as your first one, because the difference between no cake and one slice of cake is much greater than the additional enjoyment you might get from a second slice when you've already had one. You might like a third slice, but you'll get even less pleasure from that third slice, and you might reach a certain stage when you just don't want any more cake. And this is a very basic way of thinking about diminishing marginal utility, where the marginal value you derive from a good is less the more you have. So your £50 note is more valuable to you when it's your first £50 note compared to a £50 note given to a millionaire who already has £1,000,000. And this gives us one reason to support an equity-weighted framework, because the value of innovation for those who have very little or who are disadvantaged is likely to be worth more to them than to those who already have a lot. And this is not just a theory about cakes or philosophical diagrams. The UK's National Institute for Health and Care Excellence makes funding decisions about which treatments should be publicly funded using something they call a severity modifier. So the point is that they weigh treatments more heavily when they benefit those with severe health issues, those who are more disadvantaged in terms of health outcomes. So the benefits of treatments are not calculated uniformly, but weighed towards those who have more severe illness. And we see in NICE that this results in decisions that cause more resources to be focused on conditions that are more severe than those that are less severe. On the right-hand side there is an image of John Rawls, arguably the most influential political philosopher of the post-war era, and one of the most influential philosophers of the past 100 years more generally. And Rawls, many of you will know, argues that when designing a just society, we should model impartiality so that we don't know what position we will occupy in that resulting society. So we're behind this veil of ignorance where we don't know what class or income level we will have, or what level of education or deprivation we will have, and so on. And modeled in this way, Rawls argues that we would design a society that's based on equality and priority to the worst off through what he calls his difference principle. And so he thinks that if inequalities have to exist, then these should always be to the advantage of the worst off. And if Rawls is correct, then the equity-weighted framework is one way that we can operationalize this demand, and that it's the framework that would be chosen by those standing behind a veil of ignorance. The final justification we can look at is around what we can call asymmetric vulnerability. So I've explored the significance of vulnerability for health ethics more generally in other work, but the core insight is that people have asymmetric capacity to bear risks and harms. So the more advantaged people are generally able to tolerate risks and harms better. They have more reserves and more buffers and more buffer room, whether in terms of wealth, knowledge, or social capital. And they're able to absorb innovation risks much better and forego marginal benefits much easier than less well-off groups. So insofar as we have obligations to distribute burdens and benefits fairly across people, then this provides us with an important reason to adopt an equity-weighted framework. So that is the bulk of the theory I will cover in this talk, but I now want to turn towards some practical considerations around how we can put this framework into practice. So how can we actually change the innovation life cycle or think about innovation in our real world so that it would broadly reflect this framework? Well, I think there are many important steps we can take. So firstly, we can focus on creating incentive structures and improving existing incentive structures to really embed an ethics first and equity weighted perspective. One place to start is in NHS commissioning decisions. So NHS commissioning decisions, whether done by integrated care systems at the more local level or national level procurement exercises, can introduce additional points for suppliers' tenders that have a clear equity benefit. So when suppliers bid for a particular service to provide a service to the NHS, these procurement organizations can also weigh equity in a much more serious manner, alongside considerations of value for money, effectiveness, and so on. So equity is already considered, but it could have an even greater weight than it currently does. We could also consider equity VIP lanes, where suppliers who have an equity framework or an equity promoting product can have additional lanes to propose these to local commissioning groups and to bypass the usual process for procurement. The MHRA, or the Medicines and Healthcare Products Regulatory Agency, which is the UK's regulator for medicines and healthcare products, could have more stringent requirements around what is approved to the market in the first place. So healthcare products would have to show that they are robust across various groups and don't carry the risk of harming, to an undue level, those from certain groups. In other spaces, you've had creative proposals from Thomas Pogge and other philosophers around a kind of health impact fund, where alongside the medicines patent system, you could have a fund that would reward innovation that really has a big impact on those who are the worst off. So those who have a big impact on health outcomes, even if they treat conditions that people are otherwise not in a position to buy money for. The economist Joseph Stiglitz has often, talked about prizes, not patents. And this is the general spirit of the idea that this could operate along the patent regime. It's also important to look at the underlying research ecosystem. So a lot of research is done in universities, and funders such as UKRI, Horizon Europe could look much more closely at the requirements for responsible innovation. So making sure your data is representative, making sure that those you recruit represent the groups who are less likely to be represented in existing treatment protocols, for example. These bodies already think about responsible innovation, but it's important that this is made stronger if we really want to put an equity first approach. So let's return to that pulse oximeter example from the start of the public lecture and think about what it would mean to embed ethics and equity from the design stage. So I think we should start by making sure we interrogate starting assumptions. So a lot of the early design around the pulse oximeter simply assumed away the problem of skin tone. It assumed what we might call skin tone invariance, that it doesn't change. Or it assumed that the product would be effective across all ranges of skin types and tones. But ethics gives us a good tool to question the underlying, arguments, the underlying suppressed premises behind these ideas. We can also start by being clear about who we're trying to help. What are the identified harms and benefits? Who is likely to benefit and why? And we also need to explain maybe what trade-offs we're making. So if we're likely to benefit a certain group but not others, we can be explicit about this and realize that this comes with ethical trade-offs rather than sweeping it under the carpet. We could consider an implementation pilot, using a hospital, for example, that is widely diverse and represents a wide variety of patients. That's the design stage, but also we looked at, ex post or after the rollout. We want to look at innovators' obligations. So they don't stop there. We have to think about those who have duties to monitor their products, to think about post-deployment monitoring, labeling, and so on. And these should be done both by innovators based on their own ethical and corporate duties, but also external bodies, whether in the public or private sector. And so there needs to be bodies who can keep up with the post-deployment monitoring and introducing tweaks and redesigns so that we can really see a fluid process where ethics is really embedded into the innovation life cycle from design through to rollout and beyond. Many of you might think that this is a kind of naive proposal, that we run the risk that we will stifle innovation, progress, and remove any incentives for progress. So, how can we respond to this kind of charge? I think there are three things we can say. So, firstly, as I've already highlighted, we can look at creating and maintaining incentives to encourage responsible innovation. And so that could include commercial incentives around procurement and commissioning, but also incentives around the research process itself to make it so to make ethical research much more well, first of all, much easier, and also to make it that you need to have that kind of system to be competitive in the innovation market, at least when it comes to public procurement. Secondly, even within the private procurement stage, we know that consumers are increasingly ethically minded. So ethics can make a lot of business sense. Consumers vote with their wallets, and we know that even if it might look like a cost, a lot of companies are really seeing an important increase in consumers who give them allegiance because of their ethics and their corporate values. And thirdly, we sometimes just have to accept that there are constraints on innovation that need to exist for ethical reasons. So there are lots of innovative ideas we could explore, but sometimes they can be opposed because the risk of harm they pose to others might be too great. And we take this attitude when it comes to, engineering innovations around weapons or around dangerous impacts on the environment. The second objection is what we might call something like epistemic uncertainty. So it's a concern that we can't always predict the risks and benefits in advance. So how can we really put this framework into account if we don't know what will happen? It's also the case that some benefits and risks might be accidental or unforeseen. So it seems naive to have innovation constrained by equity-weighted harms and benefits. Again, there are a number of things we can say. So, firstly, we're concerned with reasonably predicted outcomes, not necessarily actual outcomes that are foreseeable. So we can be fairly confident most of the time how these benefits and risks will unfold. We're not asked to predict every single thing that might happen. We're just asked to predict what we can reasonably be confident of it being the case. And of course, ex post ethical responses, so these are, remember, responses that we do after deployment, these are always available. So we can always respond even after implementation and deployment. And we can respond to issues that arise at this stage. And finally, in some ways, the focus should be on the importance of procedural fairness. So it's not just about the actual outcomes, we also care that the process is fair. And in some ways, the equity-weighted framework also emphasizes that we want the process to be fair. So we want it so that disadvantaged groups can feel that they have been considered in the innovation space. We can conclude the sort of theoretical discussion at this point with just a brief discussion of what procedural fairness means and why it matters in the innovation space. So procedural fairness basically says that it's not just the decisions that we make, that matters, it's also how we make them. And procedural fairness needs to underpin decisions in innovation as it does in any area of public decision making. So many of you will have heard, criticisms of the power that tech companies have, the so-called tech bros, and these so-called concerns about technocracy. And this comes partly from concerns around the influence of decisions that are made in secret or made without any kind of publicity. So we don't know how these decisions are being made. And theorists such as Norman Daniels and James Sabin have presented this account for healthcare, where they say we want decisions in healthcare to be made that are publicly accessible and transparent, reach fairly with good reasons and open to being challenged and appealed. We don't want reasons based around bribery or around favoritism. We want these reasons of innovation to be based on sound judgment and impersonal reasons. And one way to think about the practical value of procedural fairness is to reflect on the case of DeepMind and the Royal Free Hospital. So many of you will know that the Royal Free was recently had an issue and was actually fined by the Information Commissioner's Office because they gave Google DeepMind access to over 1.5 million patient records, including identifiable information. And this was to help DeepMind develop a tool for detecting acute kidney injury. Now, a key part of what made this case especially troubling was that the Royal Free did not notify patients of or seek their consent about this entire enterprise. And so there was an undermining of procedural fairness around publicity and transparency into these patients that had no awareness that this was the case. So this diagram that I'm just showing up here can broadly summarize the key message that I've covered in this lecture. So we want ethics to underpin the entire innovation life cycle from the conception and innovation idea stage through to the design and the implementation. So it should constrain healthcare innovation and be central to these innovative ideas from the very beginning. So at the idea stage, we want to make sure we understand the populations we're targeting, but also who's actually the worst off affected by this condition. And if our target diverges from the worst affected groups, we might need to think about why that's the case. That can be done through, for example, an equity impact analysis, where we think about what is the effect of what we're doing on these worst off groups. And we need to identify relevant ethical values and trade-offs. So if we are innovating for a target group that is not the worst affected, it's not to say it's not justified, but we have to realize here that there is an ethical trade-off that we have to make explicit. At the design stage, we want a responsible innovation plan. We have to have data sources that are representative, that are reliable. We want to make sure we're speaking to stakeholders in this space, patients, other innovators, as well as regulators, and so on. But perhaps most importantly, at the design stage, we want to do error analysis by subgroup. So what that means is it's not enough to show that the treatment works generally for everyone. We want to see how it works and doesn't work for specific subgroups as well. And this really helps us to think about something like that pulse oximeter example, why it might not always be the same situation, the same benefit across the population. And if you're business oriented or you want to think about how you can do this, you can have something known as an equity weighted scorecard. So you have a kind of fairness target and a metric, and you can formalize how you measure equity so that there is a robust and clear account for how you think about who is benefiting and who is harmed. And finally, at the implementation stage, you also want a transparent summary of limitations. So if you know in advance that certain groups are more likely to suffer from side effects, then these should be made very clear. There should be active monitoring. The black box label in the FDA in the US, the yellow label or the yellow card scheme in the MHRA in the UK. You want to be aware that there are these important steps around active monitoring even after the product is deployed. And this can be done through something like a dynamic ethics audit. We want to always reflect on the values and the ethical risks that we're thinking about. And two things to keep in mind about this diagram is that there are multiple off-ramps, and there's an arrow that can show the dynamic and fluid nature of this approach. So the off-ramps basically symbolize that we should not be afraid to abandon an idea if it fails to meet our ethical conditions and violates the demands of health equity. So this might sound demanding, but it's a way of grounding innovation for a purpose, at least in the sphere of health. So we want innovation to have a ethical purpose and an equity promoting value. And we can always have an off-ramp at every stage of the process if it appears that we are really at risk of failing this. There's also a dynamic feedback. So if issues are found at any stage, we should be prepared to go back to the idea and design and the idea and design stage and rethink how we're doing this. So let me conclude by summarizing what I've argued. So I've argued that health innovation is not just about what diseases we can cure or what technology we can do or what technology can do for people's health. Equally important is for whom such benefits, such innovations will yield benefits. And if I've emphasized one thing, it's that health innovation needs to put ethics and equity at its forefront, not only at the implementation level, but at the design stage. And so this is an equity-weighted framework, or embedding ethics and equity throughout the entirety of the innovation life cycle. So I will conclude my talk there, and thank you for your attention, and hand back to Nora and the team for any of your questions.
Thank you so much, Johann, and the very thought-provoking talk. And we do already have some questions. I'd like to encourage others who are listening to scan the QR code. It will take you to the Slido, and you can put your questions in there. So we have some initial questions, and I think they very much get to the heart of many of the points that you were making. But the first one I'd like to ask you, Johann, is even if we have the right ethical theory and framework, how can we get politicians on board with supporting ethical and responsible innovation in healthcare?
Thank you very much, Nora, for that question. So this is a real challenge. But one thing we can point out is that citizens care a lot about ethics. So some colleagues of mine have recently run a survey looking at how citizens think about AI in the health realm. And actually, we find that a significant proportion of people really are not prepared to trade off ethical values for improvements in efficiency, for example. And what this shows us is that politicians, if they care about, the votes, for example, about popularity, they have no choice but to think about these considerations. So one way is just to speak to politicians and say, look, there's a real democratic demand for fairness and equity in the AI space. And we see this in not just in that survey that we ran, but also in op-eds, in public discourse around AI. There's a real concern around algorithmic bias and around all of this. But also, politicians can, one of the ways we're doing in a lot of education, including at GBSH, is training future health leaders to think about ethics much more strongly. So in our programs in the school, within the MBA program, the EMBAs, the DBAs, all the way from the undergraduate to the executive programs, I've come to these sessions to talk about ethics. And what that shows us is that actually there are ways that you can embed ethics in a much more central way for both the future of education, not just in the healthcare setting, but actually for politicians. And it starts with showing people the importance of thinking about these problems in all aspects of their education.
So I think that's very important, and I appreciate that nuance as well. Um, but one of the things, of course, in healthcare is, and anywhere you go in healthcare around the world, is innovation, digital technology are seen as the answer to a various serious workforce constraint. So, one of our colleagues has put in a question here on how can we address AI innovation and primarily those negative impacts that are impacting disadvantaged groups, as we see from data center developments in lots of low-income countries and subsequent water conflicts that are exacerbated by the development of AI and many of the technological tools that at the other end, we see those as the great hope. So how do you address that tension?
Great. So I actually think that the framework provides the response to the solution, right, to this problem. So if we think about the weighting function I mentioned around the risks and harms and what benefits on the other hand, we have to also look at what I've sometimes called the hidden cost of AI. So when we look at AI deployment, as our colleague mentioned in her question there, there's a lot of concerns around, for example, water use. And we tend to concentrate a lot of data centers in more deprived communities. Now, that's a harm that's related to innovation that is relevant to our equity-weighted framework. So when we think about how we distribute and mitigate risks around innovation, that is also the kind of consideration we need to think about. And if all the benefits are being diverted to particular countries or particular regions, that's also a distributive concern. So what we want is that the burdens of innovation, whether it's water, electricity, noisy and large data centers, we want these to be spread fairly so that we share both the risks and the benefits. And on the AI workforce challenge, yeah, I perhaps diverge from my colleagues. I don't think AI is the magic bullet or the silver bullet that will solve all the problems in healthcare. In many ways, it can actually, poorly implemented AI can increase workload because you have to learn how to use it. It can make things worse when it makes errors and you have to change it. We know from other work that it can have particular implications for certain groups. Actually, some people have whether older people have a harder time learning AI technologies. And so all of this, I think, is important to keep in mind when we think about the costs of AI innovation as well.
So yes, very, very good and very thoughtful response. So one of the things, and we've got someone who's a senior director at a European drug regulator, and as you articulate and say quite convincing, there's some need for us to think about, the inequalities, this tension, and how do we bring ethics to the table to do that? So they're asking a very important question. And do you have tips on, if you are a policymaker or you're working with policymakers, how can you improve their ethics knowledge and awareness as they grapple with some of these issues?
Great. Well, I think the first step is attending a UCL lunch hour session on ethics is a very nice start. Hopefully, but no, I think it's important that there's also a role from academic ethicists like myself and others to have outreach on this area because it's very important. And I've already spoken about some programs at UCL that put ethics at the center of what we're doing. More generally, I think policymakers actually think about ethics a lot more than they think. In my work with policymakers across New Zealand, in Australia, in Europe, all of these people are thinking about ethics. They might just not realize it. And so I gave one example. People talk about health equity. That's an ethical idea that's used very widely in the health setting. And so what we need is just a way to help us think through the different values, the different balances that we're doing here. Um, I also think there's a lot of scope at a practical level for engagements between policymakers and regulators and academic and business partners. So events that bring people together, institutions that have, for example, professors of practice, where we bring in, senior executives and senior leaders in the public space into conversation with the university academics. This is really valuable for forming this kind of link to show that what we're doing in the university is not just purely theory. It might sound dense and theoretical, but actually it has a lot of practical impacts that, in many cases, these policymakers are already thinking about anyway.
So yes, I couldn't agree more. But another question that's come through, and again, I think it's significant, and that is often when we're thinking about healthcare and we think about benefits and we think about risks, they're almost always greater for children and young people versus adults in terms of lifelong health. And of course, we also are in a period where we've got lots of people aging, so we've got lots of demand at that end. So how do you ensure this is considered in terms of ethics within the healthcare setting?
Yeah. No, I think this is also an important question. And one way is just say, actually, in some ways, the framework I've outlined is flexible because I don't define in advance who is the worst off or who is the best off. And that's on purpose because in some contexts, as I think this question is pointing out, children or older people might be in a group that is worst off, in part because we have less clinical trial data on many of these groups, partly because of concerns around the vulnerability. But within the innovation framework, we need to think about whether younger people and older people do fall within the worst off groups from innovation. In terms of how the framework would deal with that in terms of knowledge, I think this is where philosophers and ethicists can't solve everything, right? So we need to also have expertise from pediatricians, from geriatricians, from scientists who are experts in understanding the effects of say innovation with regard to these groups. So in some ways, it's an answer that says we have to also recognize our limitations. I can provide a framework. I can't tell you exactly how to calculate risks and benefits. But luckily, we have a great university and a great ecosystem with all these colleagues who can answer these questions around how we calculate and think about benefits and risks. But I agree with the principle that these are important to think about. But luckily, we have others who are experts at thinking about the effects of these innovation effects.
Yeah. So again, AI is constantly on all of our minds today, and we're encouraged on the one hand to use more and more AI to find solutions. And there's of course, a debate within healthcare about the ethics of that, the reliability of it, accountability, who actually is accountable when you're having decisions made through AI algorithms. How does that factor into your framework and your thinking about healthcare and ethics?
Yeah, so I think there's two ways of thinking about ethics and AI. So one group says that AI is something totally distinctive. The technical phrase for this is sui generis. We think that AI is something unique, something totally different from anything we've dealt with before. And the other kind of view is that actually we already have the existing tools to think about innovation, and AI is just a way in which we're applying this. Now, I sit on this second group. I think AI does raise interesting practical problems, but what I've tried to show is that philosophers don't have to shy away from this, or ethicists don't have to shy away from this, because the tools around equity, around fairness, around justice, all of this are already our bread and butter. We think about this on a day-to-day professional basis. And ethics in AI is just a way of applying these existing values and principles to a problem, very important problem, emerging problem. But there's no reason why we need to reinvent the wheel and create entirely new approaches from the start. And I think that's one of the challenges to actually show both applied ethicists and also doctors and other people working in this realm that you already have the skills a lot of the time to deal with ethics. You just need to look back through some of the principles that exist and how we can apply these in a critical and useful way to the problem of AI. So I don't think we need to reinvent the wheel actually to deal with a lot of these problems.
So I think again, one of the kind of charges is that you sound a bit naive, and particularly when we're thinking about low and middle income countries who are desperate to, find solutions, policymakers, solutions to maximize the number of people benefiting from healthcare and minimize those costs. So, how do you kind of balance out these questions of if the ethical dilemma is more on the poor, we should then be more cautionary about how we deliver that to the poor when they're actually very much focused on cost effectiveness to save more people, and particularly those people less able to care for themselves.
Yeah, no, so I think the challenge of the low and middle income countries or LMICs is a really important consideration. And what I would say about that is here it's important to think about the harms of omission and harms of not acting, which I mentioned in my framework. So we know that in many cases, the people who would benefit the most from AI innovations, but also other kinds of technological innovations in health, are those in LMICs countries. Um, and so one way to think about this is that that actually weighs in favor of the benefit side. So the benefits should be weighed more heavily because they are likely to help those who are in these poorer countries. If the risks are equally high, that also might mitigate against that. And so what we need there is a kind of more balanced discussion. If it's high risk but potentially high benefit, how should we think about that? If it's lower risk but has high benefits for these LMICs, then I think it's quite clear that there's a strong moral obligation on this framework to implement and to roll out that system or design systems that help LMICs context.
So just a final question, then how do we balance the kind of long-term versus short-term? Because in the short term, I might be able to adopt some of these practices, AI, technology, and they may have a very impactful, measurable impact. However, the long-term impact of climate change and the sustainability may not be there. As a politician, I and most politicians in most places in the world have a very short time horizon. So how do we get them to think about these in a way that extends even their own political relevance?
Yeah. No, no, great. So I think that the temporal horizon is really important when it comes to both ethical reasoning about health, but also AI. One important practical consideration actually is to strengthen participation in politics by young people. Because young people are digitally literate, they're very aware about the future of the planet and the health system. And having younger people involved will actually drive a lot of these politicians to think about things beyond the electoral cycle. Now, that's also, you might think, a naive view, right? It's as naive to encourage young people into politics. But when we look at a lot of the research around young people involvement in politics, we see actually a really strong positive effect in encouraging politicians to broaden their temporal horizon. So that's one kind of core, hopeful note that we have a lot of young students who are very interested in this problem. And they can apply quite a lot of pressure actually on politicians to think beyond the electoral cycle. But I think your question around how we get politicians to think on board with this is probably something that requires a broader shift in how politics is conceived. So we might want to think about health being less partisan, for example, so that it's not just scoring points, who has the flashiest MRI scanner for this electoral cycle, because that is good for vote grabbing or for a photo op. But it's less good for the long-term structure. And so what we want is we want a kind of maybe an arm's length commission or some kind of at least incentives that allow better collaboration that transcend party political lines so that we can really look at the problems that go beyond a single electoral cycle. We see that slightly with the NHS, long-term plan. We see in other countries, but a lot more needs to work to change the sort of political structure. But young people, I think, we can see hope in that, and we can hopefully come up with incentives around how to think about how we change the political structure.
All right. Well, look, Johann, thank you so much. A fantastic lecture. I want to thank the audience for very engaging questions, and I'm sure they all had many takeaways from today. So again, wonderful to have all of you. I know this has been recorded, and I'm sure there'll be ample opportunities for people to continue to engage with this material. Thank you.